So this is a talk about lactate, which probably you guys have heard me talk about in the department before that I think probably we're over ordering. I started giving this talk 3 years ago to the previous residency I was at and to other departments within the hospital I used to work at, and I have not really seen any improvement. Um, so at this point, I don't want to sound dramatic, but I do think crazy or loco is the correct term for what we are doing with lactate. So hopefully, after this lecture, you will see the light. Now, I do want to say, though, that I do not think that lactate is a bad test. Lactate is a very, very good test if you are using it correctly. However, if you are indiscriminately ordering it on all patients with any sort of abnormal vital sign, or even with normal vital signs, then you're absolutely doing the wrong thing. So, number one question: what causes a patient's lactate to be high? How about an intern to respond to this? Rich. Okay, so your answer is anaerobic respiration. So something that causes you to do more anaerobic respiration will cause your lactate to be up. Is that what you're telling me? Okay. And that's a common description of how the lactate increases. So we'll talk about how that's not completely correct during this lecture. Clemens, you have a question. Yeah, good. So some people will divide up types of elevated lactate into type A and type B. And type A will be hypoperfusion, and type B will be other causes that are not hypoperfusion. However, I think that that's a bad way of thinking about it, and I'll explain why. The short version is that almost all of your lactate generation is from what is called type B, which is supposed to be the less common. Okay? Gomez, yeah. Hypersympathetic response. That is correct. That is an important component of it. So we will talk about that and how that relates. All right. So before we get into the crazy overuse of lactate, a few basic things. Number one, the terminology. The correct term is lactate, not lactic acid. If you say lactic acid, I know what you mean. It's okay. However, if you want to sound smart, you use the term lactate. Even labs will sometimes order a lactic acid in the order set. That is wrong. So lactate and lactic acid are in an equilibrium. Lactate is the ion that you can actually measure, and in your body, almost all of it is lactate and not lactic acid. So if you want to sound like you know what you're talking about, you call it a lactate, not a lactic acid. Next, a better term is hyperlactatemia, not lactic acidosis. If you don't like that fancy term, high lactate, elevated lactate, okay? But lactic acidosis is usually, or at least often, incorrect. And here's why. You can have a high lactate, yet not be acidotic. And about 50% of the time that you have a high lactate, you're not acidotic. So if you're calling someone who has a lactate of 2.5 having a lactic acidosis, there's a good chance that you're wrong. It's better to just generally call it an elevated lactate or hyperlactatemia, as I prefer. All right, so the basics. So Rich mentioned this already. So where does lactate get generated? It's going to get generated from glycolysis. And nobody wants to spend a lot of time talking about the biochemistry, so I promise you I won't either. But you start with glucose, and then you go through glycolysis, and glycolysis actually generates pyruvate. You may or may not remember that from med school. From pyruvate, if you have oxygen available, it gets shunted and creates, or shunted through the Krebs cycle and creates 38 ATP. Without oxygen available, it can be converted into lactate, which gives you a couple ADP, I think. I forget exactly. So the prevailing theory on how lactate is generated, what most people believe, is that if you're in an anaerobic state or you're not getting enough oxygen due to hypoperfusion or hypoxia, that you shunt more pyruvate to becoming more lactate, and hence your lactate increases if you're hypoperfusing or hypoxic. That is the prevailing theory. And indeed, if you look at many textbooks or online descriptions of the way a lactate works. Most of them will tell you something along these lines. I copied this from one website that was describing how a lactate gets elevated, and it says that tissue hypoxia leads to increased glycolysis use and thus increased lactate. And the Surviving Sepsis campaign, this is not their most recent, this is one iteration ago, said, quote, "We suggest targeting resuscitation to normalize lactate in patients with elevated lactate levels as a marker of tissue hypoperfusion." So, in other words, what I'm telling you is that the vast majority of people believe that the lactate is primarily generated through hypoxia and hypoperfusion. And we will talk about how that's not quite right, although thinking about it that way won't always lead you astray. It will sometimes lead you astray. So we'll clarify that later. But before getting into exactly how lactate becomes elevated, we'll talk about specifically why this is even a lecture topic worth talking about, namely how we've gotten to the point that we are ordering lactates all the time. And there are a bunch of reasons that we're ordering lactates all the time, but the number one reason, of course, is that we have to do it. Okay, so the federal government has decided, CMS, the Center for Medicare Services, has decided that you must do it. You must do it for any patient with severe sepsis or septic shock. And you must do it within 3 hours. If you do not do it, your hospital will not get paid for those patients, and you will probably get in trouble. So you must do it. And not only must you order the first one, but you must order a second one within 6 hours if the first one is greater than 2. And in our hospital, I've noticed we don't pay as much attention to that second part in the emergency department. Hopefully somebody else is ordering them later. Specifically, at HCA facilities and in our hospital, there's something that's a little bit different. The lactate still is supposed to be within 3 hours. However, our goal for antibiotics is within 1 hour, which sort of just pushes everything up. And frankly, our lactates are generally being done within 1 hour, although the requirement is still within 3 hours. It's just if you're going to pull the trigger on the antibiotics, you might as well do the full sepsis bundle and get the lactate with it. So what this ends up doing, of course, as many of you know, is that any patient who has any hint of having sepsis thus has to get a lactate, and generally within 1 hour, because that's when you're ordering the antibiotics. So what are the implications of that? So the lactate helps define severe sepsis. So some of you may have heard that there is no longer severe sepsis. A few of you have heard that. Tina is nodding her head. So that's really confusing. So I'm just going to give you a quick aside that in 2016, the Society for Critical Care Medicine met with the European equivalent of that society and decided that they wanted to change the sepsis definitions, and they took away severe sepsis as a thing. It's not a thing, according to them, yet the federal government still thinks it's a thing. So based upon how we get paid, this is still relevant, but if you ask some critical care specialist, there's no longer severe sepsis, all right? So I wouldn't worry about this too much because the definition of sepsis changes like every 2 years, which means that probably we should stop trying to define it because it must be really hard to define. But that's just my opinion. So sepsis plus lactate greater than 2 equals severe sepsis according to CMS. And if that is the case, if that means if you have a patient with an infection, a lactate greater than 2, you must get blood cultures and give them antibiotics. You've already gotten the lactate. If their lactate is all the way over 4, they now meet the criteria for septic shock, which not only mandates blood cultures and antibiotics, but it mandates 30 cc's per kilogram, and that does not matter if the patient has an ejection fraction of 5 from severe heart failure. It does not matter if they have end-stage renal disease and make no urine. It does not matter if their heart rate is normal and their blood pressure is normal. No matter what, if you think that they have an infection and sepsis with a lactate greater than 4, you must give them 30 cc's per kilogram according to the federal government, or you may not get paid. So, as you can see, hopefully so far, that the lactate can be over-ordered due to the metrics that we must hit, and the implications of ordering it may lead you to doing interventions that may or may not necessarily be the right one for the patient. So does this make sense? Well, here's the argument for lactate. The argument for lactate is that lactate is actually a pretty good, maybe even very good prognostic marker for a patient with sepsis. And we've known this for many, many years. This is 1970 data. In 1970, they knew that if you check someone's lactate and it was really high, that patient had a high chance of dying. And take a look at this. Lactate of 12, we're talking about almost 100% mortality back in 1970. Okay? So I was quoting this, guessing this sort of to Carla the other day when we had a patient who was septic shock with a lactate of 13, and the ICU refused. I said, this is like a 95% mortality. This seems kind of silly to refuse this patient. But they did, and amazingly, he's fine on the floor. So we must be that good that we resuscitated him so well that he was in that he was in that top couple percent that's actually survived. Although, to be honest, the mortalities are better nowadays. This is 1970 mortality, right? But this is 1970s treatment. We're talking about nearly 100% mortality if you had a lactate of 12. To be even more clear and more specific with lactate, not only do really high lactates indicate that the patient is likely to die, but small elevations in lactate suggest that the patient is more likely to die. So what I mean by that, if you take a look at this graph from Critical Care Medicine 2009, again, we have lactate versus mortality. So at even small lactates, there's a linear relationship between the lactate and the mortality, meaning that if you look at somebody with a lactate of 1.5 and compare them to a person with a lactate of 2.5, the patient with a 2.5 is actually more likely to die, even though both of those patients have near normal, mildly abnormal to just upper limit of normal lactate. So you start seeing the relationship between lactate elevation and mortality even at low lactates. And this was one of the arguments for the reduction of the normal lactate value from what used to be 2.2 to 2. And maybe some of you didn't know that, but a normal lactate used to be 2.2, 0 to 2.2, and is now 0 to 2.0. We lowered the bar, basically, to make more patients severe sepsis. All right, very good. So the thing that is supposed to make lactate really good is that it can predict the future. So what I mean by that is you may have a patient who has a normal blood pressure, but a lactate of over 4, that patient is likely to soon become hypotensive. And that's the argument I was making to Carla on the patient with lactate of 13. I'm amazed he did not become hypotensive. And I had another one, actually, Tina, you left the other day, but another, it's this old lady, her lactate was 6. We gave her some fluids. ICU was telling us to admit to IMC, and then 5 minutes later, her blood pressure was 70. Okay? This happens all the time. So if you see a legitimate sepsis, yeah, Danny was there, right? Yeah. You see, yeah. If you see a sepsis patient, and they actually have a lactate of 4, and they seem like they might be sick, take that very seriously, because that means that patient is likely going to crump. In fact, if you look at the Manny Rivers trial, if you compare the patients who had normal lactates but hypotensive to lactates above 4 but not hypotensive, they have the same outcomes in the ED. You follow that? Hypotension versus normal, no more tension, but elevated lactate over 4, same outcomes in the Manny Rivers trial. So in other words, you can basically say, even though, yes, they're not actively hypotensive right now when they have a lactate over 4, they're probably going to be hypotensive soon. And so for me, if I have sepsis and the patient looks sick at all and they have a lactate over 4, I consult ICU. And then 95% of the time they become hypotensive. 1% of the time, 5% of the time, somehow we've resuscitated them so well, I guess that they don't. Anyways, that's the value of lactate. Its prognostic ability. And so that is how you're supposed to use it, is for its prognostic ability. Another thing that is supposed to be a good thing about lactate is its ability to help you measure resuscitation. So there is retrospective data that says that patients who clear their lactate do better. And this one particular study found if their lactate clearance is at least 10% within 6 hours, they have lower mortality rates. But in general, and you can use this in not just sepsis, but trauma or anything where you're doing a resuscitation, that you can follow the lactates over time, and it helps you decide if your resuscitation is adequate. This is a mandate now from the federal government for sepsis, which I think is a little bit strong, but there is some data that using the lactate to guide your resuscitation may be useful. So that's the argument for lactate. It has prognostic abilities, almost be able to predict the future when you have a high lactate in a septic patient. But there are problems with the lactate. So let's review those. So the biggest problem with regards to the use of lactate in general is that virtually nobody knows what they're doing with the lactate. They don't know why it's elevated, and then they don't know how to interpret it, which leads to all sorts of mismanagement when you don't understand how to interpret the lactate. So, as I said before, the prevailing theory on how lactate is elevated is that through anaerobic glycolysis, through hypoxia or tissue hyperperfusion, you do more glycolysis and you get more lactate. So it means that you must have hypoxia, tissue hypoxia, or tissue hypoperfusion. So I'm going to tell you that that is actually a minor component of why your lactate is elevated. So this is data from a New England Journal of Medicine study from 2009. These are ABGs, or ABG results from 4 Mount Everest mountain climbers. So the key points here are the oxygen sats here and the PaO2s. So you are unlikely to ever see PaO2s this low in a living person in any other situation. Okay? You've probably seen ARDS patients before, but you probably haven't seen a 27 PaO2, even in your ARDS patient in the ICU. So these are pretty much the most hypoxic people you could ever get, plus they're climbing a mountain, and so therefore you would expect them to be very elevated with their lactate, right? Well, you can look at their lactates here, and they're 2, 2, 2.9, 1.8, and 2.2, okay? So you have somebody with massive hypoxia who's climbing a mountain, and their lactates are almost normal or normal, okay? This one's a little high, 2.9. So if somebody had such profound hypoxia and you believed that hypoxia was causing a lactate elevation, how would you explain this? Clemens. Yeah.
These guys are like avid mountain climbers, just like the hemoglobin response to it increases. Wouldn't the body's, I'm going to say that, like, let's say lactate actually was hypoperfusion, wouldn't the body find compensatory mechanisms? Because having a high lactate can't be good for your body either.
So, okay. There's a lot to that question. In the interest of time, I will say just a couple things. So, if you're saying that there's some sort of compensation in these people that are reducing their lactate, I'm sure there is. Yeah, absolutely there is. My point was simple here, that this is profound hypoxia here, and yet the patient's lactates are normal to mildly abnormal. The second part, having a high lactate bad for you? Actually, lactate is a fuel for your body that is good for you. However, having a high blood lactate is a bad prognostic sign that you're having to generate that lactate. But if I gave you lactate, it actually might help you rather than hurt you. See the difference there? Associational, not causational, with elevated lactates. All right. So, second thing, if you think that tissue hypoxia is causing elevation of lactate as the primary mechanism, it is a little bit difficult to explain how in septic patients where they actually measured the oxygen in the tissues, it actually increased in septic patients. And local tissue oxygenation increased in septic patients, with the theory being that there's some sort of dysregulation such that they stop utilizing oxygen appropriately. So at a tissue level, it is strange that the oxygenation seemed to increase, and that's according to a critical care medicine study from 1994. Also, if you believe that low tissue oxygen is the result or is the cause of elevated lactate, why not just give the patient more oxygen? In other words, if you have a septic patient and you want to increase their oxygen going to their tissues to help them and to reduce their lactate, just give them supplemental oxygen. Put them on 100% non-rebreather even though their oxygen saturation is already high. This has been studied, giving supplemental oxygen that's not needed to try to reduce lactates and try to improve outcomes, and actually it makes patients worse. And that was demonstrated in an article in New England Journal of Medicine 1994. You don't follow that, Clemens? You do follow it. You do follow it. Okay, good. So I'm telling you that I don't think that not enough oxygen getting to the tissues is the primary means by which lactate is generated. So then what is the mechanism? And the mechanism is catecholamine activation of the beta 2 receptor. It turns out that activating the beta 2 receptor activates glycolysis and lactate formation. And I'll show you the study that proves that. The second thing that counts for lactate elevation is inability to clear the lactate. So you should know, you should memorize that lactate is cleared 70% by the liver and 30% by the kidneys, which means that a patient who has liver failure usually has a little bit of a lactate elevation. And if they get septic, you'll see very, very high lactate elevations in liver disease patients. Similarly, if you just randomly check a lactate on severe renal failure patients, you're likely to see a little bit of an elevation, and that's just because they're not clearing their lactate. All right, so I wanted to do something that demonstrated that by activating the beta 2 receptor, you could increase the lactate. Fortunately, we have a medicine that activates the beta 2 receptor, that's albuterol. So I did a study. I started it when I was a third-year resident and then finished it a couple years ago. And what we did is we took 28 volunteers, and those were residents and medical students, and we randomized them to either receive albuterol or placebo. So they received either 10 milligrams of albuterol or they received a nebulized placebo. Their initial lactates for the albuterol group was 0.87. It was actually slightly higher just by chance, 1.08 in the placebo group. We gave either albuterol or saline. The lactate went up from 0.87 to 1.63 in the albuterol group, and it actually went down from 1.08 to 0.93 in the saline group. So the difference of an increase of 0.77 compared to a decrease of 0.15 is statistically significant. Hence, albuterol and activation of the beta 2 receptor results in a lactate increase. So what that means clinically is if you check a lactate on somebody who has an asthma exacerbation after they've already started getting treatment, you're probably going to false sepsis alert them, okay? And this happens more in COPD exacerbations because you're like, oh, it's COPD, maybe it's pneumonia too. If you got the lactate after they've already started getting their treatment, your lactate's going to be falsely elevated, although it's not falsely elevated. It's just elevated due to a reason other than just sepsis. It's due to albuterol. All right. So this is just a tangential study, but I thought that this was a good study because I did it also. It doesn't prove my point, but I'm going to tell you about it anyway. So we did another study. It's kind of a similar idea, but this time the question was, does giving lactated ringers increase your lactate level? So as you probably know, lactated ringers has lactate in it. So my theory was that if you give somebody a bunch of lactate, their lactate goes up. Surprisingly, people thought that it didn't increase your lactate level before this. So I said, well, I bet you it does. So we, again, took 30 volunteers, med students, and residents, and we either gave them lactated ringers or normal saline. 15 volunteers in the lactated ringers group had initial lactate of 1.06, and the 15 volunteers in the saline group had initial lactate of 1.05. This time we gave them 30 cc's per kilogram. Where did I come up with that number? That's the septic shock amount of fluids. So I figure if you want to really know when this is going to come into play, let's use the big volume of fluids that patients in septic shock get. By the way, I was a volunteer in my own study. Getting 30 cc's of fluid when you don't need it is not very comfortable. It's pretty bad. So 30 cc's per kilogram to healthy volunteers with no symptoms. And the lactate went from 1.06 up to 1.99 in those receiving lactated ringers. Interestingly, it also went up a little bit in the normal saline group. Why would that happen? I actually not 100% sure. Maybe just random chance, or maybe giving a bunch of fluids to somebody who doesn't need them actually causes your lactate to go up. I think that's also possible. Here, the increase from 1.06 to 1.99 is statistically significant. So comparing the pre to post, there's a statistically significant rise in your lactate with lactated ringers. And this increase of 0.37 comparing pre to post is not statistically significant. The thing that made this paper harder to publish, I had to submit it a couple times, is that when you compare, because this went up by 0.37, comparing 0.77 to 0.37, it misses statistical significance by a little bit, if you follow that. So in other words, one more time, comparing 1.06 to 1.99, pre and post, that's statistically significant, but when you're comparing the change from one group to the next, it doesn't quite meet statistical significance. But when I look at the results, to me, it's convincing that giving lactated ringers increases your lactate. Every single person who got lactated ringers in this group, 100% of them's lactate went up. It's just that some of the ones in the saline group went up too, but far less consistent a result. So I don't know if this proves 100% definitively that lactated ringers increases your lactate, but I tend to believe that it does. And this does not mean, of course, that you should not give lactated ringers. Actually, you should give lactated ringers because, again, having a high lactate is just a prognostic indicator, but actually your lactate level going up because of giving lactated ringers is not necessarily bad for the patient. It's just a confounder that if you are giving somebody lactated ringers, their lactate level might not drop as much because giving them that extra lactate might slightly push the lactate level up a little bit, if you follow that. Some of you followed that. Anyways. All right. So you don't believe me. You think I'm making up all this crap about the way that lactate is generated. I provide you a little bit more evidence. So patients who overdose on beta blockers. Turns out patients who have severe overdoses on beta blockers and even die from beta blocker overdoses often have a normal lactate. Why would that be? Because again, they can activate their beta 2 receptor. And so in this study here from Clinical Toxicology 2010, the vast majority of ICU level beta blocker overdoses had normal lactates. Any questions about that? All right, very good. So a couple other issues with lactate. So I told you before that lactate has prognostic significance. Lactates over 4 portend a bad prognosis. However, patients can have septic shock and actually have a normal lactate, or patients can have death from sepsis, I should say more specifically, and yet have a normal lactate. And so this happened in a substantial number of patients, even in the Manny Rivers early goal-directed trial. And so if your patient has a blood pressure of 60, don't be reassured that the lactate's 1.5. Say, hey, the lactate's only 1.5, so this patient's going to be fine. I see this mistake made all the time as well, that if you understand lactate, you should understand that a high lactate likely means that the patient's going to do worse. But if the patient looks like crap and their lactate's normal, you should not ignore the fact that the patient looks like crap. So just to be more clear on that, Critical Care 2009, they published a study that demonstrated that patients who had hypotension but yet had a lactate less than 2 still died 15% of the time. So in other words, one more time, that you do not need to have a high lactate in order to suffer a severely bad outcome from sepsis. here's the thing I forgot to mention. This is important. So if you understand that a lot of the lactate generation is coming through beta 2 activation, you should recognize that some people, due to their underlying physiology, might not generate as much lactate. For example, an adrenally insufficient patient might not have catecholamine drive and therefore may not generate a sufficient lactate. So in addition to the fact that a high lactate does not necessarily mean, a low lactate does not necessarily mean the patient is going to do well, it is noteworthy that many things besides just sepsis can cause the lactate to go up. Yeah. Right. So here are things that can cause the lactate to go up besides sepsis. Any sort of shock, cardiogenic shock, anaphylactic shock, hemorrhagic shock, trauma, anything, okay? This is a huge problem made by everyone in the hospital, which is that I admit somebody with a heart failure exacerbation. The nurse does a lactate, it's 2.5. I don't give the patient antibiotics because they're not septic, because they have a heart failure exacerbation. And then somebody sees the lactate of 2.5 and writes sepsis on the chart, like 20 hours after they've been admitted. And hence I have a sepsis fallout for a patient who never was septic, because somebody didn't understand that a lactate elevation can be due to anything. It does not necessarily mean it's sepsis. It simply means that the patient is activating their endogenous catecholamines because something is going on. It's their fight or flight response. That's basically all that the lactate elevation really means. So please do not see every elevated lactate and say that the patient is septic. That just means that something is going on in the patient. That's all you can say. A bunch of drugs can do it. A bunch of drugs can increase your lactate. I showed you albuterol. I know that one for sure. Epinephrine is this exact same mechanism as albuterol. There are a bunch of other stimulants, cocaine, meth, even a whole bunch of caffeine could increase your lactate. Anything that's going to increase your sympathomimetics, and in particular your beta-2 receptor agonism, is going to increase your lactate. The other ones here, metformin, antiretrovirals, propofol, act on it through a different means. So they poison your mitochondria. They poison your mitochondria and prevent you from being able to do aerobic metabolism. So that actually is the anaerobic metabolism. That's how you're getting your lactate elevation from those. And then I said already, lactated ringers, slightly controversial, but I'm on board that I think giving lactated ringers increases your lactate. I said renal failure and liver failure previously because that's how lactate is cleared. Seizures probably by a couple mechanisms. Number one, if you have a seizure, you have a sympathomimetic surge. And second, all that shaking potentially might cause some lactate elevation. Ischemic bowel or ischemic anything, ischemic limbs. And that is, again, from a lot of that is probably through anaerobic glycolysis, although there's no doubt a sympathomimetic surge if you have a ischemic limb or ischemic bowel as well. Just exercise. Don't check a lactate if somebody has just gone for a run just to see if maybe they might be septic. That would be stupid. All right. Exercise, of course, is a way of getting your catecholamines to go. Carbon monoxide and cyanide poisoning. This is, again, poisoning the mitochondria. All right, so the point here is that an elevated lactate does not necessarily mean the patient is septic. You must consider the context of the patient. If you see a lactate of 2.5 and they seem like they have heart failure, their lactate elevation is from heart failure. It is not from sepsis. All right, so the last bit of this is about repeat lactates. So here we don't focus that much on this. However, I'm wondering if we're falling out. But although lactate clearance is associated with better outcomes, my general thought is that mandating the repeat of lactates for every lactate over 2 is unnecessary and not supported by the evidence. So let me explain. I said before that a lactate clearance greater than 10% within 6 hours is associated with a lower 60-day mortality. That is based upon retrospective data from a study from 2004. However, prospective data have not shown that lactate has been beneficial, with the exception of one study. So that study was published in, what year was it? 2010. So that study compared patients in the ICU with lactates greater than 3, and the arms were these: continuous SCVO2 monitoring, central venous oxygen saturation, and lactate monitoring versus nothing. And they concluded from this trial that by doing continuous SCVO2 monitoring and lactate monitoring, I believe the lactate monitoring was every 2 hours for all lactates greater than 3, that by doing the lactate monitoring, that by checking lactates every 2 hours, that you are helping the patients. Recognize how bad a study this is. There are 2 manipulated variables in this study. One is that the patients were getting continuous CVO2 monitoring, and 2, they were getting lactates every 2 hours versus no mandated monitoring at all. So not only are there two manipulated variables, but just the fact that every 2-hour lactate checks requires the physician to know about the patient every 2 hours, thus forces the patient to have to assess the patient in 2 hours. So this is not a study that showed that serial lactates help patients. It just shows that doing closer monitoring helps patients. Yet they concluded from this, and Surviving Sepsis Campaign uses this study to say that we should all be doing repeat lactates for high lactates. So this is terrible. This should not happen. This is a bad study and the wrong conclusion made from it. So I think that there is value to repeating lactates in certain circumstances, but doing it every single time, especially based upon low quality data, is a massive waste of time and money. And other studies have been done and have showed no benefit to doing serial lactates. So why has one study that was not done correctly influenced our practice so much? I have no idea. I have cited one of the studies that have showed no benefit to serial lactates. So I'm going to give you an example of a patient, and you tell me if you think that this would help you to get a repeat lactate. This patient 75, septic shock, the initial lactate's 6, the initial vitals, heart rate's 115, and the blood pressure is 75/50. In 2 hours, due for another lactate, their blood pressure is 77/52. So you must order another lactate. That's what the federal government says here. But I propose to you, let's say the lactate now is 0.1. Lactate's as normal as you can get. You're like, all right, cool, this guy's totally resuscitated. We're fine, we can probably just back off here. Doesn't need anything else, right? Or let's say the lactate is 50, right? In either case, this patient's still super sick, right? So who cares what the repeat lactate is? It's completely irrelevant. And if you think about this, every single one on a case-by-case patient basis, is the lactate going to help me or not on this individual patient? What you'll come up with is that most of the time the lactate's not going to help you, but yeah, in some cases, a lactate might help you. And so really it should be left to the physician discretion to decide if getting another lactate or getting a lactate at all might be beneficial for that patient. So here's what I think about when a lactate might be useful. A lactate, first of all, is not useful if the patient is obviously super sick. If the patient has a blood pressure of 50, a heart rate of 150, and their GCS 4, you don't need a lactate to know that that patient's sick. Okay? You might argue maybe for doing serial or doing a lactate to be able to do trending of lactates, but you clearly don't need a lactate for your emergency department care when the patient is that sick. Similarly, if the patient is 22 and they have an obvious strep throat, you don't need a lactate to decide if that patient is sick or not, regardless of their vital signs. When might a lactate be useful? If you've got a patient who seems like they maybe are a little bit sick, but their vital signs are pretty good, like they're just tachycardic to like 110, 115, and their blood pressure is okay, or maybe their blood pressure is like borderline low. That is the perfect patient to use a lactate on because it gives you prognostic information that might help you figure out which way that patient's going to go. Because if you get a lactate on that borderline patient and it's over 4, I'm worried. If you get a lactate on that patient and it's normal, I still need to watch that patient closely because, as I said before, patients can have normal lactates and do really bad, but I'm slightly less worried. So this is the point of the lactate, is to help you decide on that in-between patient how aggressive you should be with your care. And so you get a lactate over 4 on that in-between patient, I think you should consult the ICU, even if the ICU doesn't understand the literature. Okay? Questions on that? No. All right. Another time that I like to use the lactate is you'll get these patients and their blood pressure is like low, but they don't seem like they should otherwise be sick. Like they came in just because they feel a little lightheaded or they measured their blood pressure and it's low. By getting a lactate that's normal, I'm reassured that either maybe they just run a little bit low on their blood pressure, or maybe it was just like a transient thing that's mild medication related. So having a normal lactate on a patient where they have like this low blood pressure but otherwise seem fine, and having a normal lactate on that patient makes me pretty reassured. So that's another time I like to use the lactate. And also, lactate is very useful for screening for ischemic bowel. So if you have a patient with a bowel obstruction who seems to be having more pain than you'd expect, I'd get a lactate. Make sure that they're not developing ischemia with that. Or if you can't do a contrast CT scan on somebody who has bad abdominal pain, you could get a lactate as a screen for ischemic bowel. Questions about that? No. Okay, so you're probably saying, who cares? We'll just do whatever we're told. We're residents. And to some extent, you do have to do that. But you should know that there are, of course, harms to ordering all these lactates. The first is the cost of a lactate. I actually don't know what it is at our hospital. I know what it is at the last hospital I worked at. It was $210. That's a small cost amongst the thousands and thousands of dollars we waste on a daily basis. But it needs to be considered if we're going to order a lactate on every single person. This is millions of dollars cost initiative if we're not getting any benefit out of it. This is millions of dollars wasted unless there is a benefit, which I think there is some, but I think it's too small to justify the amount of money we're spending. And then the big one is unnecessary escalation of care. So this is, again, you got a patient and they seem like they have, for example, heart failure. Somebody checks a lactate, it's 2.5, and suddenly they're code sepsis, right? So you have to fight for that patient not being code sepsis, because you're going to harm that patient if you do blood cultures, antibiotics, and God forbid fluids on that severe heart failure patient just because you've misinterpreted their lactate. Or if you are not recognizing that a patient can die from sepsis but yet have a normal lactate, if you're misinterpreting lactate in that way, you can also harm patients. So this is why it is essential for you to understand all of the things that cause a lactate to go up, what a high lactate really means. That is how you will practice the best emergency medicine. So these are some summary statements. So lactate generation, I should say, is not primarily from tissue hypoxia. There may be some component of tissue hypoxia generating the lactate in some patients, but actually beta-2 activation is the primary mechanism by which the lactate goes up. The lactate does not have great sensitivity or specificity for sepsis. Many things can cause the lactate to go up, and you can die from a sepsis even with the normal lactate. And I believe that mandating repeat lactates is potentially harmful, as it has not been shown in prospective studies to be helpful. A couple other closing comments. This is a few years old now, but some of you may know that in 2014 and early 2015, there were 3 studies done that compared protocolized sepsis care to sepsis care done at the discretion of the physician. Which one did better? The same, okay? They did the same. So we did 3 big trials published in New England Journal of Medicine all 3 New England Journal of Medicine, And what they showed 3 times comparing protocolized care to physician discretion was that there was no difference. So my question is, why, shortly after those, did we get a whole bunch of new metrics for sepsis that is going the exact opposite direction of what the literature just said? The literature said that we could just do whatever we think is best, and that works for the patients. All right, sorry, that was a little bit of a rant. Yeah.
I just pulled up Pennsylvania 2019 law. All our prices are listed online.
Oh, okay.
I just found that it's $349 per lactate.
That sounds about right. Oh, cool.
I googled it. That's what it is.
I will update this. Thank you. All right, so if you're discouraged by the fact that I have just now told you that you have to do a test that may not be helpful to the patients and is probably wasting $300-something per patient, that's okay. I'm discouraged too. First, let me tell you that you still must follow the rules. You must get lactates on the code sepsis patients. You must. Otherwise, you'll get in trouble. And the hospital won't get paid sufficiently, then they'll figure out it was you, and then they'll come back to me because I did this lecture, and I might get in trouble. All right, so you still must follow the rules. You must get lactates. However, the point of this is not for you to stop getting lactates, but is one, to interpret them better, and two, as the next generation of physicians, for you to avoid the same mistakes that the leadership is doing now. Okay? The leadership has misinterpreted the literature and got us ordering a test way too much, wasting money, resulting in unnecessary escalation of care. And it's because people did not interpret the medical literature correctly. So what you're going to do is do better than that. All right? So the next time a non-specific marker for just something happening gets suggested to be a test that we order all the time, you should be like, I don't know about that. Maybe that's not the best idea. Procalcitonin fans out there, this is lactate part 2. If we start having to order a procalcitonin on every patient who has such and such in the ED, I'm going to be pissed, all right? I'm going to blame it in part on you guys for not pushing back more, because I'm pushing back. But that is basically what lactate is. That is basically what procalcitonin is. It is just a marker that something is going on. That is it. Anybody have any questions?